Alaikum. Welcome to the Cerebrovascular Grand Round brought to you by MENASO. I'm delighted to have been a part of this team and thank you to the invitation from Professor Suhail Al-Rukn to be a part of this multidisciplinary approach to this exciting topic today on unruptured intracranial aneurysms. We have a panel of sponsors who have made this event possible, to which we are grateful. I'll be co-moderating this session with a fellow colleague, Dr. Fawaz, who I'll hand over to in a minute. Myself, I am a neurologist in adult clinical neurology at the Aga Khan University Hospital in East Africa Medical College in Nairobi, Kenya. And we have the agenda laid out here with excellent speakers on different elements of dealing with this topic. And we'll have a case-based question and answer session towards the end, and then we'll open up for more questions. We'd like to thank MCO for helping to host this and organize this, who will also help us keep time. So with no further delay, I will hand over to my co-moderator, Dr. Fawaz, who will introduce the speakers, and we will then go into the lectures. Thank you and enjoy. Good evening.
Thank you, Dr. Delaraj, for this introduction, and thank you, the organizer, for organizing this meeting. So today we are going to do the multidisciplinary discussion for very nice and controversial subject, which is unruptured intracranial aneurysms. To have it with different views from neurosurgery and neurology and neurointerventional radiology point of view, we try to understand it better. Without further delay, I would like to introduce the first talk by Dr. Faisal Al-Abbas. It will be given by Dr. Hosam, because Dr. Faisal Al-Abbas is operating right now, which is going to be the clinical attribute to decision on unruptured intracranial aneurysm. Thank you, Dr. Hosam. Dr. Hosam, he's the consultant vascular and interventional neurosurgery, as well as neurocritical ICU. He's in the MAM region, holding a Saudi Commission for Health Specialty regarding neurovascular diseases. Please welcome Dr. Hosam Al-Jehani.
Well, thank you for us. I'm presenting on behalf of my colleague, Dr. Faisal, who is held up in the OR at the moment. So I'm going to share his presentation. It is about the clinical attributes that gives us a hard time when we're dealing with unruptured aneurysms. Nothing to disclose, and aneurysms that have never ruptured. This is how to define this. We need to simplify this as much as we can, because the more we look into details, we might find that actually the aneurysm leaked, or there is little deposition of hemosiderin somewhere. And we actually see this in surgery sometimes, that we are operating on so-called an unruptured aneurysm, and you see hemosiderin deposition on the cortex adjacent to the aneurysm. So this aneurysm must have bled at one point in this patient's life. So we can agree to call them aneurysms with no evidence clinical imaging, and they're usually discovered incidentally or with coexistent pathology, like a meningioma, and you find an aneurysm, or in the context of head injury or brain tumors and family history of subarachnoid hemorrhage. Unruptured intracranial aneurysms, they are they are present often in the population. 3.2% have aneurysms that are unruptured, and that goes to 16.8 million people. And they can be discovered more and more with the liberal use of thrombectomy these days. We can find them more often, and this is kind of a pre-selection of vasculopaths who can form aneurysms more than the general population. The unruptured aneurysm, as I said, it's not something that has been clinically or radiologically demonstrated to have an aneurysm, but these patients can have, when they rupture, they have the common symptoms that we all know: the headache, the coma and such. But some patients, the aneurysm growth causes mass effect, and that can cause cranial nerve deficits or neurological deficit, or compression if the cortex has been compressed, or seizures, and so on. We can group them into smaller ones that are asymptomatic and often incidental, finding in imaging, and those who are between 10 millimeter and 20 millimeters, those present with headache or seizure or cranial neuropathy, and those more than 2.2 centimeters, they can present with headache and visual loss and pyramidal tract dysfunction and facial pain. Sentinel headache is something that gets mentioned a lot in the context of subarachnoid hemorrhage, and it's problematic because if you ask someone who has a subarachnoid hemorrhage, did you have a headache 2 weeks ago, they will always say yes, because most of us will have a headache once a week or once every other week, so it might be a problem. But if we correlate it with some of the scores of aneurysm rupture that we can see in the next few slides, we can see some difficulty that we can put 1 to 1 together and say that sentinel headache is predictive of aneurysm rupture. So here, again, I apologize for the mixing of the slide. I think it's a compatibility issue between Dr. Faisal's laptop and my laptop, but we can see here that there is a age preponderance for patients above 50 years of age, and women have a higher incidence or prevalence of unruptured aneurysms than men, if adjusted for other comorbidities. There is a significant discrepancy between unruptured aneurysms, 2,000 per 100,000 population, and subarachnoid hemorrhage, which is 10 per 100,000 population. So for each 2,000 people, there will be one rupture for each 200 patients harboring an aneurysm. So who are the patients who are unlucky or lucky in a way, as Dr. Faisal is saying, to have the rupture is patient-related factor, aneurysm-related factor, and external factors. So the patient-related factors that are found to push the pendulum towards rupture are female gender and age. As the age advances, the risk of hemorrhage increases. And some genetic disorders like polycystic kidney disease and collagen vascular disease like Ehlers-Danlos or Marfan syndrome, and association with arteriovenous malformation due to fluid dynamic shifts. Comorbidities like hypertension, family history risk is a significant one. Multiplicity, if a patient has more than one aneurysm, they have preponderance to form more aneurysms, and these aneurysms are more likely to rupture. Modifiable risk factors like smoking or alcohol abuse or cocaine abuse or contraceptive pills, these are all controversial to a certain degree, but they can be factored in the discussion with the patients. So we have modifiable risk factors that are hypertension, smoking, and alcohol, and non-modifiable risk factors as age and previous history of subarachnoid hemorrhage and familial aneurysms. As we go through the years, we see that the pickup rate of unruptured aneurysms is increasing. So from 2005 to 2017, this is a review from a prominent group of epidemiological surveys in Europe, and you can see that the numbers are increasing with time, and the age brackets maintains itself. So the age bracket between 30 to 70 is increasing. Those younger than 29 are still steady at a low incidence. There are some genetic predisposition in certain areas in the world, namely Japan and Finland, for some genetic constituents in these populations, and they have a higher incidence and higher prevalence of aneurysms, as we can see. And the other thing that is the other domain of factors that are related to unruptured aneurysms is aneurysm growth. So if the aneurysm changes size as we follow it from a year to year, or every other year, or whatever time bracket that we choose, then that's a risk factor for hemorrhage. The other factors are daughter sac, and these are like weak points in the aneurysm, and the shape, whether it's irregular, and then we can see that there are some certain factors like thin wall region that's picked up on MRI, and MRI wall imaging that we can been recently introduced into our routine practice. So here again, the Japanese population, they have higher risk of rupture than the Western counterparts. And when we look at the recommendation for imaging, the American Heart Association 2015 guideline stated that DSA can be useful in compared with non-invasive modalities and identify cerebral aneurysm if surgical or endovascular therapy is being considered. DSA is reasonable as most sensitive imaging for follow-up, and that is the problem because we have CTAs and MRAs that fall below the threshold of detecting an aneurysm, so DSA is still remaining the gold standard. CTA and MRA can be useful if correlated with DSA in suspicious situations or patients. It is reasonable to perform an MRA as an alternative to follow-up for treated aneurysms, and DSA to be used only if you want to escalate therapy or retreat the patient. To treat or not to treat, the rupture is fatal because that carries a 50% mortality, and the cumulative mortality is increasing, and mostly it's like front-loaded in the first month of the hemorrhage. And 60% of patients who survive, they have some sort of a permanent neurological deficit of different gradations, and only 25% go back to their normal life. The cost of the treatment of unruptured aneurysms versus ruptured aneurysms, with the clipping, it doubles the cost, and with the coiling, it increases it up to 70% because the intervention material are not cheap. So why do we treat unruptured aneurysms? It's always a controversial topic, and guidelines, and this topic cannot yield itself very well to guidelines because of the variability, and you can see on the right-hand side the natural history tree for these aneurysms. They can remain as an irregularity, it can be a focal irregularity, it can rupture right at the beginning. If you look at the right-hand side at the top column, which is the arrow D, the aneurysms like just formed and ruptured right away. So that is what we're dealing with. We're not dealing with a predictable disease that you catch at a certain point in time and can understand its behavior. So that is what happens, and patients change in their life. So a patient in their 20s or their 30s, they have an aneurysm. When they're 40 or 50, they're different. They're different protoplasm. They're different human beings, although carrying the same name, maybe different facial features, but their aneurysms might change as well. So some of the ways to put some control on this is having objective scales. And one of them is the FACES, and the other one is the UTAS, or Unruptured Intracranial Aneurysm Treatment Score, and the ELAPS, which is the earlier subarachnoid hemorrhage location, age, population, size, and shape score. So if you look at the FACES score, it puts the attributes that we spoke about. So population with the North American, European versus the Japanese versus the Finnish. And the risk factors with a modifiable, non-modifiable, and then aneurysm factors, so hypertension, age, and size of the aneurysm, and earlier subarachnoid hemorrhage and the location. And you can see that each gets a score. And here you can look at in the graph. So with the score, the increments in number increases the 5-year risk of hemorrhage. So if someone gets a score of 4, they carry a 0.9% risk of hemorrhage. So it's like a 1% risk of hemorrhage in 5 years. But if they have a score of 10, then the risk is 5%. And when one can glean out of it is that if you have someone who is symptomatic or the aneurysm is enlarging and the FACES score is more than 4, then we can justify the treatment of these patients. Asymptomatic or less than FACES of 4, then FACES of 4, then you can observe these patients. I'll skip this for the sake of time. The UTAS is a more complex system, and it's related to it's like the discussion that goes in neurovascular rounds or cerebrovascular rounds or pizza rounds or whatever people you choose to eat in those meetings, is to the back and forth discussion that we have. So you look into factors that favor the treatment, and these are on one column, and the factors that push you away from treatment, and you do the sum of these two. And if you achieve a 3-point difference between the two, you should treat this aneurysm. So that is how you can come up to a conclusion. So here, again, these are applicable to case by case, and we can see that it's more robust than the FACES score, but it's not yet been validated in large-scale studies, and it's complex, and you need expert opinion to put into these, because some of the factors are requiring detailed history or detailed imaging findings that cannot be done by a junior colleague or an intern in the team. The ELAB score, again, it's akin to FACES score that gives patient factors and aneurysm factor, but it included some additional aneurysm factor other than the shape, which is the irregularity. And you can see that with the increasing number, there is an increased propensity for hemorrhage. So less than 5 is less than 5 points of score. It's collectively 8% of a 5-year risk. But when you look at more than 25, it's like a very high percentage. It's predictable in the 3-year to a 5-year rupture, and one can use it in replacement of the FACES because of more aneurysm details that are provided. But again, as clinicians, we tend to go back and forth, and as Dr. Fawaz said in the introductory meeting that we had, it's like always a back and forth discussion, and you kind of look into your colleagues and try to pick their brains and see if you can have any additional information that will help you decide on this, because the decision is not very easy unless the patient has very clear-cut aneurysm factors. The aneurysm is increasing, or they had a rupture from another aneurysm. Everything else is room for debate, and one can have it from themselves, and they can talk to their colleagues. And we are fortunate these days that we have people treating these diseases or these aneurysms from different disciplines, than the intervention neuroradiology from radiology background, and from neurology background, and from the neurosurgery background. So we all have our prism that we apply to reality, and we can see the patient from different angles, and it comes to a better decision, hopefully. So again, we're still not there yet in terms of coming to a decision or conclusion. And I'll stop here because of the time.